Hello, welcome to this webinar about minimal invasive dentistry, also called minimal intervention dentistry from NIOM Oslo. My name is Frode Staxrud. The concept of minimal invasive dentistry has developed over the past 15 to 20 years as a result of increased understanding of the caries process and development of new adhesive restoration techniques. One might think MID is about a new school of dental philosophy, an alternative way for dental care. It's not. I like to see MID as an update of old teaching based on acquired research knowledge and clinical experience. This is about the concept of cariology and tooth wear, and how we can perform dentistry today. Treatment of caries and its consequences comprise approximately 90% of all dental work in Western countries. Concerning everything from prevention via non-operative treatment to restorations of all kinds, including crowns and bridges and implants, etc. Basis for MID is a fundamental respect for original tooth tissues and their well-being. I'd like to read this disclaimer. Neither NIOM nor the presenter has any commercial interest in products mentioned in the presentation. Presented data can be found in published literature cited in the presentation. Conclusions are based on presented data. Other products may have similar or different effects. It's all about disease control, modification of oral flora to eliminate risk of further demineralization. It's about patient education, meaning explain the causes of oral disease, mainly caries and tooth wear, and what the patient can do to prevent or stop it. It's also about remineralization of early lesions, in fact, lesions at any stage. Understanding the chemistry and biology of caries to take advantage in possibilities of remineralization, either preventively or as non-operative treatment. Minimal operative intervention of damaged hard tooth tissue when this becomes necessary. And finally, it's about repair of old restoration, if possible before replacement. To make a treatment plan, we need diagnosis based on accurate VCO tactile examination supported by radiographs and careful interview with the patient for information about medical conditions and personal contact. Get to know the patient. The findings must be evaluated in the light of risk assessment, a thorough risk assessment resulting in tailored treatment measures at individual level to prevent or treat negative development. Caries risk factors that have to be considered thoroughly to make good decisions and an individual treatment plan would be caries experience, caries activity, saliva, diet, hygiene, fluorides, and finally social and economical issues. We have limited possibilities to change socio-economical factors chairside, so we will leave this point here only to have mentioned it. First, caries experience. Is it possible to predict future events? We can look to epidemiology and try to foresee what will happen, but that is totally dependent on conditions that don't change. The most reliable predictor has shown to be caries experience and the caretaker's clinical judgment. Caries experience is defined as the sum of all present and previous caries activity, meaning active or arrested caries lesions, missing or filled teeth, expressed by the DMFT or DMFS index. It tells us whether the patient is susceptible to caries. Caries activity is what it's all about. How caries sick is the patient? First, We'll look at the number of new lesions graded from 1 to 5 that has emerged over a defined period, for example 1 year. This is called incidence. Then we will find out whether the lesions are active or arrested, and we assess the lesion's progression rate. Looking at plaque or biofilm, whether the lesions are hard or shiny, soft or opaque, dark or light. We see whether they are involving enamel, dentin, or the root. And we also look at the localization in dentition. The aim or goal is always disease control, meaning reduce the caries activity to 0. These 4 factors are possible to change in various ways. And it is through these the patient and the dental worker, read dentist or dental hygienist, can cooperate to achieve desired results. We have to assess the quality and amount of saliva. Saliva's most important functions are oral clearance, buffer systems regulating acid and base balance. Saliva has antibacterial properties. It lubricates and moisturizes teeth and mucosa, and it's responsible for pellicle formation, and through this, regulation of electrolytes on all surfaces. Insufficient amount of saliva or dry mouth means increased caries risk and erosion risk, as saliva plays a crucial role in demineralization, remineralization cycles. Its quality and quantity needs assessment. There are many conditions leading to dry mouth, for example Sjögren's syndrome, sarcoidosis in certain gland-attacking forms, radiation damage, cancer treatment, and we have glandular diseases, and of course medication, many prescriptions, especially psychiatric and heart medication. Stimulation of saliva, or in many cases substitution, is important in order to help avoiding caries and tooth wear. Diet and carbohydrate intake. Bacteria ferment sugars to acid. The formation of acid starts immediately after intake of fermentable carbohydrates, leading to an increased caries risk. Immediately after intake of carbohydrates, the acid formation starts, where both the amount of carbohydrate and the frequency of intake is of importance. The age of the biofilm is important too. Biofilm must be adequately mature before its caries pathogen. It is able to produce enough acid to lower the pH under 4.5. In the range between 5.5 and 4.5, hydroxyl will leave the appetite crystals. But if we have fluoride present, it will immediately step into its place and we have no net loss of minerals. At pH under 4.5, there is no remineralization resulting in loss of minerals. So the time is of essence. Enamel demineralize and remineralize caused by pH fluctuations. So if the period of time at low pH is longer than the neutral period, the result of acid attack is caries lesions or erosions. Hygiene. Why? The purpose of hygiene is to remove biofilm, the acid-producing bacteria, as the activity of the caries process lies in the activity of the biofilm. Hygiene is to remove food or debris or carbohydrates, and very important, support fluorides through toothpaste. For the 10% that comprise the risk group, we need to find additional program designed to optimize the treatment based on the risk assessment. Bad hygiene leads to increased risk of caries. Our job is to help patients understand why the disease occurs and how they can avoid it. Most important is the regular disturbance of biofilm. They must be encouraged to good habits and find suitable remedies for the task. Fluorides is a success history of dental care services, speaking of both prevention and treatment. Fluoride supply in dentifrice combined with tooth cleansing, reed brushing, is a genial way of dental care and quite sufficient for 90% of the population already, as biofilm is removed at the same time as fluorides are distributed on the teeth surfaces. It has reduced caries prevalence in the population dramatically. The graph illustrates reduction of caries incidence in Norwegian population from introduction to the market in 1971. It is even a little bit lower today. Basic recommendation to all patients are brushing the teeth with fluoride-containing toothpaste twice a day, and to understand the importance of doing so. As to the non-operative treatment, fluoride aids remineralization as briefly described. It aids caries arrest and have some antibacterial effects. It even slows down the caries progression rate. Tooth wear. Tooth wear is a common term for irreversible progressive loss of tooth substance that is not caused by bacteria. It is usually divided in three main groups based on etiology. First, erosion is caused by acid from non-bacterial sources. Acid solution emerging from intrinsic or extrinsic sources cause chemical dissolution of hard tooth substance. It is often combined with abrasion and at any tooth surface by brushing or tongue and cheek movements, or attrition of occlusal surface by gnashing of teeth for some reason. Diagnosis based on clinical examination and carefully acquired anamnestic information is essential. Again, get to know your patient. In order to provide adequate preventive and, when necessary, restorative treatment for patients at risk, it's important to individually evaluate each patient with respect to risk factors. We have the extrinsic factors, which comes from consumption of acidic food and drinks with potential to dissolve dental hard tissue. We have the intrinsic factors, which are coming from the stomach, being different kinds of reflux or effects of eating disorders with frequent vomiting. We also have some modifying factors, which mainly are saliva, saliva's flow and its buffering and diluting properties. Saliva also influences pellicle formation, regulating ions on tooth surface. Exaggerated brushing habits will increase loss of hard tooth tissue for patients suffering from tooth wear. And we have genetic factors determining composition of appetite crystals and its solubility. It plays an important role, but are difficult to assess clinically. Treatment plans should start with non-operative measures, which means information about the condition and what causes it, and counseling about patient's awareness and actions that the patient can do. It's about fluorides with potential effects, especially against hypersensitivity, but also possible preventive effects, particularly metal fluorides. It's also about monitoring and recalls, which are important to assess development and, if necessary, operative treatment. Primarily composite restorations to begin with, and ceramics may be an alternative and can be performed as minimal as possible to restore lost hard tissue. Adhesive techniques have made this possible. We seek to do intervention as minimal as possible, whether it's caries or tooth wear, meaning operative action should be performed when absolutely necessary. That is when the biofilm in the cavitated lesion no longer can be controlled by the patient and there are no longer possible to arrest the progression of the actual damage, or there are aesthetical or functional needs. As the goal always is, arrest of disease and save sound hard tissue. Operative treatment means reconstruction of teeth after damage. Adhesive techniques, it is bonding techniques, has changed our possibilities and ways of thinking, cavity design and use of materials. Bonding agents should be used for all resin-based and glass ceramic restorations. Operative intervention should focus on preservation of natural tooth structure. Bonding. They make it possible to retain all kinds of restoration to teeth because of adhesion, which comes into being when two bodies or particles are so close that they attract each other because of physical attraction forces. It's based on micromechanical interlocking. Uncured resin flow into undercuts of all kinds before curing, and we also make use of resin interpenetration into etched dentin, forming a hybrid layer. For all these purposes, we need a fluid bonding, an agent that can flow over any surface and get very close to the tooth structure or restoration material. Last but not least, we also rely on macromechanical retention through preparation technique. Operative treatment. Think minimally invasive and bear in mind when drilling. For primary restorations due to caries or tooth wear, it's wise to limit preparation to removal of infectious dentin and frail enamel. Preparation design should follow the extension of the carious lesion or damage. Surface that has been exposed to saliva for a while should be slightly roughened with rounded diamond burr, the outer 20 micrometer. That increases surface energy and enhances wetting. I have to mention stepwise and partial caries removal as pulp and hard tissue saving strategies. When it comes to replacement, ask yourself, is it necessary to take it all out? Is the quality of remaining restoration good enough to remain? And when it comes to repair, parts of old restoration can be retained, if possible, before taking it all out. And we have some guidance on repair or replace. Remember the restorative death spiral. Restorations have limited lifespan. And any filling or remaking of it will eventually lead to tooth destruction. Use your clinical experience and keep minimal invasive dentistry in mind. Have individual risk assessment for each patient. Repair when good quality of remaining restoration. And remaining restoration is larger than the repair. Successful repair requires macromechanical attachment and micromechanical attachment, and it also requires the use of dental adhesive and silane. Remember to reduce the risk of new failure. As a summary, minimal intervention dentistry is all about disease control, which I have mentioned: modification of the oral flora, patient education, remineralization of early lesions, minimal operative intervention, repair of old restorations, if possible before replacement. Finally, to the patient's best: to pay for not to fill. Preserving strong teeth provides good arguments for calculating realistic economic compensation for non-operative treatment. Why pay more for this than this, as our goal always will be to save healthy teeth for life. Thank you very much for your attention.